topic is very important. It frequently comes in the MS examination, and it having its own importance during the practical examination of spine particularly.
If anybody has any queries, they are free to ask any questions.
Can I have a caller mic?
Don't hesitate in asking the questions. Kindly clear your queries. You'll not get this opportunity again. Yes, stand up. Mic do.
Sir, in spine TB, always there will be a bony ankylosis, and in the peripheral joints, it's fibrous ankylosis. Just I want to know the reason behind this.
It is true that most of the healing in the peripheral joint takes place.
Ready?
Yeah, can I start? Friends, it is indeed an honor to have been invited by the Gwalior Orthopedic Society, by Indian Orthopedic Association, specifically by Dr. Chandra Prakash Paul, to talk to you about few topics that are of great importance to you during postgraduate teaching. And as such, Gait is not a non-clinical subject. And as postgraduates, you are expected to know everything about orthopedics. Gait is coming up as a very important investigation to analyze the problems of locomotion, fatigue, and pains in the lower limb, for the problems of limping, for the problems of decreased performance in athletes and in a common person. As the society is becoming more demanding, they want us to treat the problems which till hence were thought to be minor. One of the very important aspects of your clinical teaching has to be Gait, and from my experience as an orthopedic teacher in a medical college, I know that this topic is not really gone into details during a routine teaching. So I have devised made a small talk for you. What is Gait? It is a series of, see, every word here is important. It is a series of rhythmic, coordinated and symmetrical movements brought about in lower limbs, upper limbs and trunk to propel the body forwards. And what I have highlighted, with minimal energy expenditure. Now why this minimal energy expenditure? If you imagine that throughout your lifespan of about 60 years, if you walk only in one direction on this earth, you will be encircling the earth 4 to 5 times. That's the amount of distance that you walk. Imagine a vehicle. You buy a car, after a few years, it gets worn out. You have to sell it off. The engine is gone off. All the cylinders have burnt out, the bearings have burnt out. It is because of the wear and tear that occurs, because of the energy that goes into working of that car, that causes wear and tear. And if the same thing is going to happen to the human body, then your body won't last for a very long time. And hence, nature has devised a way of locomotion in which your body is propelled forward unconsciously without you making any effort by a mechanism which is probably at the level of spinal cord, which automatically brings about certain movements, certain contraction in the muscles, certain balancing efforts to have a normal gait. It is done in such a way that there is least possible energy used up by a human body when he is walking. And because of this, specifically, to use the least amount of energy, every individual has more or less a constant gait pattern. For an erect person walking on two legs, the nature has devised a particular way of walking that spends least amount of energy. And that's what I am going to talk about, how does this happen. Now, you imagine your whole body weight to be concentrated at your center of gravity. Where is the center of gravity? It is in front of first or second sacral vertebra, about 2 inches in front of your second sacral vertebra, somewhere deep behind, deep inside. You imagine this to be, if you are 70 kg, you imagine this to be a 70 kg ball which is centered over your second sacral vertebra. Now, if you lift this ball up and put it down, you again lift it up and put it down, you can imagine the amount of energy required to do so. But at the same time, if you just roll this ball on the floor with minimal amount of energy, that ball is going to be going a long way. Why? Because the center gravity has remained constant at that plane. It is not going against the gravity. It is not moving excessively sideways. It is traversing the least possible distance to take a body from one point to another. And that is what gait, a normal gait, all about, that you keep the center of gravity constantly, more or less constantly, as far as height and width on the distance that you are walking. So, when you measure this in a normal human being, this center of gravity during normal walking does not deviate more than an inch above and below, and does not deviate more than an inch from side to side. It literally goes in a sinusoidal way without changing its distance from the floor much and without deviating from the path of walking much. At the same time, I have used this, an act of walking in humans, an act of falling forward and catching oneself. I will be elaborating it a bit more later on. When we talk of the various aspects of gait that can be measured, you can measure the width of the walking pace, that is from the center of one heel to the center of another heel. When the person is walking, it is very little, 5 to 10 centimeters, and that's why the body does not deviate much from side to side. The step length is the distance between the one foot on the ground, the heel of one foot on the ground and heel of other foot on the ground. When you walk, the foot comes to ground, the heel strikes, and when the other foot comes down and the heel strikes, the distance between these two heels is the step length. And the stride length is when a foot comes to the ground, goes off the ground and again comes to the ground. The distance, that is, it is double the step length. A gait cycle is a condition, the movement through which one foot goes when it is on the ground, leaves the ground and then again comes back on the ground through one single step. A fixed angle is an angle that the foot makes to the direction in which the person is walking, and cadence is the number of steps per minute. Now, this number of steps per minute is more or less same in a normal walking. It doesn't deviate much. Looking at the height, the various habits of the people, again, because it has been found that the minimal energy spent is when a person is walking with the cadence of about 80 to 100 steps per minute. But when you are in a hurry, when you are running, when you are walking at a very leisurely pace, then this cadence can differ from what is normally required to have the least energy expenditure. Now, look at this vis-a-vis if you want a person to be trained for walking after some major orthopedic event. He has not been walking. Now you want a physiotherapist to train him to walk. If a physiotherapist tells that patient to walk slowly because you have an imbalance, then this slow walk is going to cause him to spend more energy, is going to tire him much more easily, and he may not be able to walk as efficiently when the physiotherapist tells him, no, walk with your normal speed. So, and it goes a long way in also deciding deciding as to on long-term walking how much is the stress is going to be put on if there has been a particular limb or injury that has been involved. So a gait cycle consists of a stance phase. The stance phase is when the foot is on the ground, and the swing phase when the foot is off the ground. I am talking of normal walking. So if you see, the stance phase is much more than the swing phase. The stance phase is 60% of times, the swing phase is 40% of times. What does this mean? It means that there is a time when both the feet have to be on ground. 20% of the gait cycle is occupied when both the feet are on the ground, and this is known as a double support. Okay? A swing phase of a leg is when the foot is off the ground, and a stance phase is when the foot is on the ground. In contrast to running, in a normal walking, one foot is always on ground. However, in running, and this differs from walking, in that there is a time in running when both feet are off the ground. You must have seen Olympic event of fast walking, in which what the observers, the referees, the umpires see is there any time when the athlete has both the feet off the ground? The moment the athlete has both the feet off the ground, he is disqualified because he is no longer walking, he is running. Okay? So in running, there is usually no double stance phase, and there is a time when both the feet are off the ground. However, in walking, one foot is always on the ground, and that is how we differentiate walking from running. The stance phase consists of a heel strike, which is also known as a initial contact when the foot strikes the ground, and then there is a time when the foot comes to the ground in fully, which is also known as a loading of the foot, and then is a phase of mid stance when the body weight is just above the foot. Then we have a heel off, and ultimately the toes off. This is the time when maximum energy is spent. It is a very explosive event where huge amount of energy, about 80% of whole energy of walking is expended here in the push off, when the gastrocnemius soleus and the gluteus contract to push the body forward. And the swing phase consists of an acceleration, a mid swing, and a deceleration. This we have variety of names that we have given to it, but only thing you have to remember that these are the events that normally take place. And acceleration, after the toes off, the knees goes, the hip and knee goes into flexion. There's knee goes to about 60 degree of flexion, and then there is a swing forward, and then gradually the limb deaccelerates for heel to come in contact with the ground for the start of a second stance phase. Then there are certain other aspects of gait that I would like to talk to you about, which determines how efficient the gait is, and that is what is known what we call as determinants of the gait. With an aim of keeping the center of gravity constant, not deviating much up and down, and not deviating much from side to side, all these events take place. Okay? So what does happen when there is a heel strike? There is a flexion of the hip of 30 degree, but the knee is in full extension. So the hip is flexed for the foot to have brought forward, the limb to have brought forward, but the knee is in full extension and ankle is in neutral position. However, as the body comes over the foot for preventing the center of gravity to go up, the knee starts flexing. From full extension, it flexes. Here the hip has come to extension, and to prevent the center of gravity from rising up, the knee has now got flexed. Okay. Now, when we look at the various muscles that are acting here, the quadriceps is acting, and now gradually quadriceps, LVS, hamstring have started contracting. Okay. Here there is a controlled flexion of the knee taking the weight of the body, and this controlled flexion is also controlled by the quadriceps. So, every event that is occurring here is to prevent the center of gravity from moving excessively up. And then as we go to the heel off, the knee is extended, and then to clear the ground, the knee comes to flexion from 30 degrees, and in mid swing it goes to almost 60 degrees. Similarly, the hip, which has begun by flexion at 30 degree, has come to neutral position, then has gone back to hyperextension but about 10 degree, and when the hip has gone to hyperextension, with the knee flex, the center of gravity will have gone down. So, the knee has extended here to again bring the center of gravity to what we want as in a single line. Ankle, when the foot strikes, the heel with the ankle in neutral position, the heel strikes, and then there is a plantar flexion of ankle, so that the effective length of the limb is increased. By this increasing the effective length of the limb, the center of gravity does not go down much. Okay? And then there is a dorsiflexion of the ankle in the heel off, and then a plantar flexion again when the toes is coming off, so that the foot does not rub against the ground when the person is walking. Here I have not mentioned the foot. Now, foot is a very important tool which interacts with the ground when you are walking. If you are walking rapidly, there is a large amount of force generated as the foot strikes the ground. This ground reaction force can cause a lot of impact and jerk to the whole of the body. To prevent this jerking of the body and to adapt the foot to the uneven surfaces, the foot remains supple when it is on the ground, so that a lot of energy is absorbed by this supple foot. How does it become supple? It becomes supple by pronation. So, once the foot is pronated, then it remains supple, it absorbs the energy, and it accommodates to the uneven surface of the ground. But when you want to have a push off, a large amount of energy is required to propel the whole body forward, and the lever that is doing it is your foot, which is going into plantar flexion and pushing off your whole body. To do that, the foot has to become absolutely rigid. If it is supple as it is pronated, then it is going to be a less efficient device to propel your body, and you are going to get fatigued earlier. So, you want the foot to be rigid, and this occurs by foot going into supination. The moment foot goes into supination, the movements between the intertarsal joints reduces to almost zero, and it acts as a rigid lever and propels your body forward. Now, look at the practicality of it. A simple condition like a flat foot. In a flat foot, the arches of the foot are such that when you put the weight on it, the foot's place goes into pronation. Once it goes into pronation, with the push off, this pronated foot is going to be a supple, non-rigid foot. So, the amount of energy required to propel the body forward will be more, and hence patients or people with flat foot tend to tire earlier, get fatigue and pain in their leg muscles when they are walking longer distance. Similarly, when the foot is off the ground, there are two things that has to be done. One is to have the clearance of the foot from the ground, so that there is no rubbing of the foot or toes against the ground, and this is done by knee coming to the flexion to 60 degree, then it starts getting extended, and at the end of the swing phase, when the heel is about to strike, the knee is fully extended so that the length of the limb is effectively long, because the hip is now flexed, and with the flexion of the hip, the center of gravity may go down. To keep the center of gravity from going down, the knee extends and the center of the gravity again is maintained. So the same thing happens. So hip has to be flexed to propel the body forward, and if the hip flexes, then the knee extends. Then again I talked to you about the ankle in plantar flexion to neutral position, and then again when it swings forward, it is again in neutral position. Why it occurs in plantar flexion? Because it has just pushed off from the ground, and it is by virtue of this forceful plantar flexion that the energy has been given to the body to propel it forward. Then there are certain other determinants of gait. The pelvic rotation. Normally when the person is walking, the pelvis doesn't remain straight. It rotates by 8 degree on each side. And this 8 degree of rotation on each side increases the stride length. And once the stride length increases, the energy efficiency increases. So with less amount of flexion of the hip, more amount of foot is propelled forward. And when you don't flex the hip that much, again the center of gravity doesn't come down much. Then there is a pelvis tilt of about 3 degree in stance phase. Now, what is this 3 degree of pelvis? You have been taught about the Trendelenburg sign and the Trendelenburg gait. When the person stands, or the amount of energy spent to keep the pelvis horizontal decreases. Every time the person is walking, as he lifts up the foot, there is a loss of balance. It is a controlled loss of balance, and before he falls, the foot comes to the ground. So, as I said in the very initial slide, act of walking is an act of constantly losing one's balance and catching itself. It is done again with an aim of spending minimal amount of energy, and with the aim of spending causing minimal wear and tear in the region of hip, which is subjected to tremendous amount of forces when the person walks or person stands on a single stance. Then there are certain other movements that are occurring: head motion, arm swing, head motion and trunk sway. All are determined at providing a certain amount of momentum to the body. If a body comes to a standstill and again pushes forward and comes to a standstill, to overcome this inertia, a lot of energy is spent, but the constant movement which is occurring with the limb and the trunk and the head provides a inertia of motion to the body, and this movement of motion prevents every time the body to spend more energy to propel the body, then comes to a standing and propelling. So there is a constant speed as the person is going forward. Okay, I will be very fast now. And very short. You go to a school to drop your nephew, a small kid of 4 years, and there is a bell, and you see a lot of kids running around or moving around. You find their heads are bobbing up and down a lot. But when you go to a Victoria Terminus station and you see the crowd, you see a huge walk with both feet spread together and arms spread out to have some balance, because they have not yet learned the art of balancing their body on a small base. But the most important, the center of gravity is moving up and down, while in human beings that doesn't, in adult that doesn't happen. And this is what the gait in a normal child differs from. See, this is a small child, just has learned to walk, and this, as he grows up, he is walking with the waist wide, arms on the side, the cadence is high, and he has looking at the floor because he is not sure of the balance. He wants to look at the floor. I am not going to go into details of the gait of the other, but I will just in short talk to you about the various other pathological gait. What is the Trendelenburg gait? As I just talked to you now, when the person has excessively damaged abductor mechanism because of variety of reasons, then the controlled sag of the pelvis is not there. When he is walking, the pelvis sags suddenly as soon as the limb on the opposite side comes off, and to prevent the body from disbalancing, the body lurches to the same side, and when this occurs on both the limbs, then it is known as a Weddell gait. This is one of the example. I hope the here, see, you can see the body is lurching on the left side. The body is lurching on the left side. Again, you look from the back, you find that the body is lurching on one side. Well, look at the pelvis, it tilts. As soon as this limb comes off, the body tilts on the same side. And to prevent the disbalance, the body lurches on the same side. This is a typical Trendelenburg gait. I won't go into details. An Antalgic gait differs from the Trendelenburg gait, in which the patient has pain while walking. This pain is because of any pathology anywhere in his limb, including a small stone in his shoe. In this, typically, it is the only gait in which the stance phase is shortened. So, if you carefully look at the patient while he is walking, you find that the stance phase on one side, I am sorry about this horizontal video, see, the stance phase, particularly the single leg stance phase, is shortened on one side. This differs from a short limb gait or any other gait where the single leg stance phase is not shortened. A gluteus maximus gait, where the gluteus maximus is weak, so that every time the person walks, puts weight on that involved hip in which the gluteus maximus is shortened. The gluteus maximus, which normally keeps his body erect, keeps his pelvis straight over the hip, is not contracting. So, the moment there is a weight on that limb where the gluteus maximus is weak, the pelvis tends to tilt forward, and to prevent the body from falling forward, the whole body lurches back. I have an example, I hope it works. See, this child has a problem with his weakness of the gluteus maximus. He has an old dislocation of the hip, but then it has effectively weakened his gluteus maximus, and when he walks, you find that every time he walks, he lurches on the back, which is somewhat similar to the Trendelenburg, where because the abductors are weak, he lurches on the side. Here, because the gluteus maximus is weak, he lurches on the back. A stiffening gait, where the person is unable to bend his knee, which is required to clear the ground. So, either he circumducts it, or there is exaggerated plantar flexion on the uninvolved side, so that the foot is able to clear. If this is involved, then the other side there is, so that the foot doesn't scrape along the ground. So, he can have both either a circumduction on the sink face on the same side, or excessive plantar flexion on the involved side. A foot drop gait you must have seen. The foot falls flat, there is a slap to the ground as the foot falls, okay? And the typical heel strike is not there, the whole foot falls flat on the ground. And even in spite of that, the toes may scrape the ground when the person is walking. A short leg gait mimics a antalgic gait, but here the stance face on the two sides remain the same. The pelvis, if the shortening is small, the pelvis tilts to the same side. There is what you call as festination, and the reciprocal arm swing is usually not there. A hemiplegic gait, arm by the side, because of the spasticity, the person is unable to flex the knee, so he has, and the toe he may be unable to do a dorsiflexion, so he walks like this. You can always find out, but you have to find the cause while the person is walking like this. An ataxic gait, when the person is unsure of the balance, something has gone wrong with his tracks which help him in balancing, then the person uses, like in child, has a broad base. The feet are wider apart, eyes are on the ground, so that he knows where he is walking, and there is, in spite of that, a poor balance, and there is a tendency to fall. There are other varieties of gait that have been described in the literature. I may not be able to go into details of everything. As such, I might have exceeded the time. I'm sorry for that. It was very
No,
extensive
Samir,
topic.
thank you very much. Really, it is very good lecture and very explanatory and in a wide way. Thank you very much, Samir.
Thank you.
Now I call next Dr. D.K. Gupta, sir. Please deliver your talk on the bone infection, chronic osteomyelitis, its pathogenesis, complication and management. Thank you, sir.
A very good morning to everyone. At first, I am thankful to the organizers of this IOA postgraduate teaching program to give me an honor to deliver my talk on the management of chronic osteomyelitis. The term osteomyelitis was first coined by Nelaton in 1834 and is used to describe infection of the bone by pyogenic organisms. As the word osteomyelitis, it includes three things: osteon, myelo, and itis. That is the inflammation of all the three components of the bone, that is the cortex and the marrow. Chronic osteomyelitis is usually the sequelae of an acute osteomyelitis, but it may also follow the compound fractures. It could be atogenic, lot of surgery, lot of implants. So it could be the iatrogenic. Sometimes we may find chronic osteomyelitis de novo, that is from the beginning. This is a case of chronic osteomyelitis. For example, the Brody's abscess, sclerosing osteomyelitis of Gait, and so on. It could be a fungal or an viral osteomyelitis. Most common causative organism is the Staphylococcal aureus. Metaphysis of the long bone is the most common site for acute hematogenous osteomyelitis, and we all know why the metaphysis is the most common site, because of rapid growth of the bone in this region. Rich blood supply, hairpin bends in the arterioles, and the attachment of the various tendons and ligaments which predispose this area for trauma in the day-to-day life. Other sites could be any part of the bone can be involved, though the metaphysis is the commonest site, but the diaphysis, small bones, flat bones, vertebrae, and the skull can also be involved. As discussed earlier, hematogenous is the most common route of infection, but others could be the direct contiguity from the neighboring focus, penetrating injuries following surgery, or following compound fractures. As elsewhere, if there is infection, there is an inflammatory response. Phagocytes attempt to contain infection by liberating certain enzymes, which cause destruction of the bone. Pus forms. This pus finds the way out through the least resistance. And in the bone, this is the Haversian system through which the pus tends to come out. As a result, there is increased intraosseous pressure, which leads to endarteritis, further leading to reduction in the blood flow. Reduced blood flow leads to ischemia or the necrosis of the bone. Pus breaks through the bone, comes to lie under the subperiosteal place. Gradually, this periosteum also bursts open, and the pus lies in the soft tissues and presents as soft tissue abscesses. The periosteum, which is elevated, lays down new bone underneath, and this is known as periosteal reaction, and later on the involucrum. The sites of rupture in the periosteum are known as the cloacae. This process may take several months or may get halted at any stage depending upon the host resistance, virulence of the infective organisms. If the infection gets completely eradicated, the necrosed bone do not separate but is gradually replaced by process of creeping substitution. Many classifications have been given. This could be based on the duration of the disease. It could be acute osteomyelitis or the chronic osteomyelitis, or it could be based on the pathogenesis, hematogenous, secondary to a contiguous focus of infection, or associated with peripheral vascular diseases. The classification have been given based on the physiology and the anatomical criteria. Physiological classification depending upon the host resistance. If the host resistance is normal, this is an immunocompetent patient with good local vascularity and the healing potentials. When the host resistance is compromised, this is the local or the systemic factors that compromise the immunity of the healing, or when the host resistance is prohibited. Based on anatomy, it could be the osteomyelitis involving the medullary cavity, superficial osteomyelitis, localized osteomyelitis, or the diffuse osteomyelitis. Acute osteomyelitis usually occurs in children. Long bones of lower extremities are the commonest sites to be involved. Occasionally, acute osteomyelitis may take place in middle-aged and elderly persons who are on IV drugs, on the central lines, on the ventrolons. It could be also due to a secondary, a contiguous focus of infection. It could be associated with peripheral vascular diseases such as the diabetes or the neuropathies, which lead to the formation of trophic ulcers. Sequestrum. Sequestrum is a devitalized avascular segment of bone surrounded by pus or the infected granulation tissue and is more dense than surrounding bone. Because of its avascularity, sequestrum do not decalcify, is more radio-opaque and heavy, so it sinks in water. So many times this question is asked in the Viva. Why the sequestrum sinks in water? And why it is more sclerosed? Its outer surface is usually jagged. Outer surface of the sequestrum is usually jagged, irregular due to the erosive process by proteolytic enzymes in the granulation tissue. The various types of sequestras are seen. The tubular sequestra is a typical example, and whole of the diaphysis could get sequestrated. This is seen in Pelvic Osteomyelitis. Sometimes we see trapezoid sequestra on the surface of the bone in Pelvic Osteomyelitis. Ring sequestras are seen at the end of stump following amputations. They are also seen nowadays around the stamen pins, around the wires of the Elizaro, or around the Shange screws. Flake or feathery sequestras are typical in tubercular osteomyelitis. Coarse sandy sequestras are again seen in tubercular osteomyelitis if they are out of cavity. Fine sandy sequestras are the example of viral osteomyelitis. Black sequestras are seen in actinomycosis. Again, a word about involucrum. Involucrum is derived from the word volvere, that is to wrap. It is a result of reactive new bone formation formed by periosteal reaction. So, involucrum is the outcome of periosteal reaction in an attempt to wall off the infection by forming a thick, dense ball. It is jagged on its inner surface but smooth on its outer surface, opposite to the sequestra. This surrounds the sequestra, so it is jagged on its inner surface, whereas sequestra is jagged on its outer surface. Cloacaes are the single or the multiple openings in the involucrum and are caused by rupture of periosteum due to pus under tension. Exudates, sequestra are extruded through the cloacae on the surface. This is a museum specimen, and on this side, this is the involucrum. In the center of it, this is the tubular or the diaphyseal sequestrum. On that side, you can see the involucrum containing the two cloacaes. They are the cloacaes. Clinical manifestations. Manifestations of chronic osteomyelitis are extremely varied. No single description can encompass them